So, so why this CPAC classification is so popular in recently? That's because the trend of arthroplasty moved to systematic approach to personalized approach. Uh, what is a systematic approach? That is a where all patients and all surgeons are aiming for the single goal, that is straight leg, so-called neutral alignment, and mechanical positioning of component, that is perpendicular to the anatomical axis, and balanced gap. The medial and lateral should be equal, and flexion and extension should be equal. So, despite the variation of the patient morphology and gap balancing and the alignment, so in the recent TKA, it considers this neutral mechanical alignment is ideal in terms of load transmission. And in the straight leg and perpendicular to this line is medial lateral mechanical stress should be equal, so balanced. If load is concentrated to the medial side, lateral can be lifted up. On the medial side, so excessive stress to the cortex and the underlying cancer bone that can cause abnormal movement and subsequent loosening. To prevent such complications, for around a half century, our goal is only one, to the neutral and mechanical functioning and alignment. However, so the alignment is アジズ、よう考えたら、見学に行っていてへんねん。
あ、そう。
うん。まあ、ただちょっと、いろんなところに廃止せんだかんから、ごめんなさいね。英語でありますね。So, many people, they recognize that the leg is not straight. It has a variation. Some patient has a valgus, another patient have valgus. Even in the normal population. It's a very important report from Belmont, 2020. The average leg alignment is 1.3 degrees in Paris. If we define 30 degrees, 3 degrees or more as constitutional Paris, so around 30% of male patients and 17% of female patients are categorized as constitutional Paris alignment. So, how should we consider this variation? In mechanical alignment, we should ignore this patient variation because mechanically, straight leg is ideal. So that is based on the mechanical strength. So it is called as mechanical alignment. But in this procedure, so align patient native alignment and patient native joint line, patient native ligament balances, and patient native kinematics are ignored because they focused on the mechanical strength. But I am the uni surgeon. But consider philosophy of uni is completely different from the TKA. As you know, in the UKA, just without the patient pre-disease or healthy situation, including alignment, ligament balancing, and joint line morphology. So, especially in the Oxford UKA, we completely ignore the patient post-operative alignment. On the other hand, also for the fixed user, and sometimes care about post-operative alignment or sometimes pre-operative alignment because they want to avoid extreme alignment. So for example, FTA should be less than 180. But in the Oxford, in the world of Oxford, we completely ignore the patient pre-disease alignment as long as they have intact ACL and intact lateral cartilage. So sometimes we find that a slightly varus alignment or sometimes severe varus alignment post-operatively. But we consider this alignment is natural or native one for this patient. So the patient native kinematics and joint line and soft tissue can be restored in this situation. The patient have the post-operative varus alignment. So previously, I used this concept for UKA. But if the patient needs TKA, we should completely change my mind. We should rebuild the patient legs to be ideal. Sometimes I should detach soft tissues or sometimes accept significant unbalance of the medial and lateral gaps. So please imagine if the patient have native varus alignment. If we cut the bone perpendicular to each axis, so this bone surface cannot be parallel. It is quite mathematical. わかる？こういう状態でそれぞれまっすぐに切ったら、絶対、so-called trapezoid. Yeah. How to resolve this problem? The previously, maybe 10 or 15 years ago, the most frequent technique was release medial soft tissue. So medial capsule, medial collateral ligament, but sometimes it causes instability or pain or difficulty in adjusting the gaps. So, but after that, so many surgeons consider that soft tissue release should be minimal, never too much. So aggressive soft tissue release has been avoided in this philosophy or strategies. So instead, some doctors accept lateral looseness, but focused on the medial gap. Medial gap should be stable in extension and flexion. If we adjust the medial side perfectly, the lateral looseness can be ignored because after the bone cut and the implantation, the load passes at the center of the knee. So lateral looseness can be neglected by the load transmission at the center. If the patient has a residual varus alignment, it can cause medial compression and lateral liftoff. Only in the case the mechanical line pass at the center of the knee joint. Lateral lift-up never occurred. Oh, this is the philosophy of medial gap technique. Maybe many mechanical users accept this concept. So in other words, medial stability is very important. So this is the most surgeons accept this concept. Medial side should be stable. But nobody knows what kind of lateral loosening can be allowed. There is no answer so far. Some surgeons say that we can aim where even this lateral looseness is too much. But other surgeons do not accept too much. So, for example, up to 3 degrees or 5 degrees of lateral looseness. But nobody knows the answer. So the second one is accept medial looseness, lateral looseness, but medial side should be tighter. Okay, the third approach is accept slight varus and varus up to 3 degrees, because previous report showed that within 3 plus minus 3 degrees can be accepted, so-called safe zone. So classically, if the alignment is over 3 degrees of varus or 3 degrees of valgus, so failure rate can increase. So within the plus minus 3 degrees, safe range or in range, so failure can be minimal in previous report. So in the plus minus 3 degrees, so cut the tibia arthritis varus or cut the femur arthritis varus. Then this gap imbalance can be decreased. Oh, this is another concept. But so that is the problem in the mechanical alignment because the patient native alignment is quite variable. So neutral alignment is only less than 1% impact. The most patients have the varus, and some have valgus. So how do we consider? In the same time, we should categorize roughly the patient has a straight leg or valgus leg and valgus. Of course, we can measure HKA in long X-ray, but this X-ray includes JLCA, joint line convergence angle. It can caused by cartilage wear. When they are healthy, they have healthy knees, the joint line should be parallel. In other words, JLCA is 0 degree. But if the medial cartilage wear is wear, so lateral open JLCA can occur. Okay, but native alignment never change as long as they don't have bone defect. bone never change. But only the cartilage can change. So if we calculate NPTA minus LDFM, we know the patient, the native alignment, where femoral and tibia joint line are parallel to each other. ちょっと難しいけども、上になったら関節面自体傾いてくるから、足全体が本来の内反よりもものすごく強調してくるの。それを仮に平行に戻してあげたとしたら、本来のその人のアライメントがわかるでしょってことになる。で、それがちょっとこの arithmetic, that is a arithmetic HK, this is a mathematical HKA, this is a not physiological HKA. Because so normal mechanical HK includes patient native alignment and cartilage weight, both. If we delete cartilage deformity, we can estimate the patient native anatomy. Because so the current trend is we should respect the patient native anatomy or alignment. Oh, that's the personalized or kinematic alignment concept. So completely change the mind. So express the patient native situation. So CPAC classification is very getting popular. そういう背景があるわけです。今なんでこんなに注目されているかっていうのは、簡便にその人の、骨の形を表せるわけです。はい。詳細についてはまたお話しいたします。伊藤先生、休みないなんか、ほんま今日なんかどっか休みって書いてたような気がしたけど。